Good afternoon. Hope you've all had an enjoyable lunch. There might still be a few people trickling in, but just in the interest of time, because we've got a fairly busy session, we'll make a start. My name's Nicola Zammit, and the observant of you amongst us will have noticed that this is not Marcus Lyle sitting to my right. Marcus has had some clinical commitments he couldn't get out of today, so I'm very grateful to Kerry Devine for stepping in at short notice. I'm a consultant in Edinburgh, and Kerry's doing a PhD with Brian Walker in Newcastle. The format of these talks will be familiar to those of you who were here yesterday. We have 6 people, experts in their area, who are going to tell us how to manage particular clinical areas. We'll need to be fairly punctual with how we move the speakers around every 15 minutes. I'm hoping that there might be time for a minute or two of questions. If the speakers use their full 15 minutes, we might have to move on, and I'm sure they'd be happy to be approached at coffee time if you have any burning questions. Just as a reminder, do please switch phones and mobiles onto silent if you haven't done so already. Tweeting is allowed and encouraged, but please don't take photographs or film any of the slides that you see. So we'll begin with our first speaker, Alison Wren from Chelsea and Westminster, who's going to tell us about how to manage endocrinopathies in HIV.
Thank you very much, and thank you for the invitation. Hope everyone had a nice lunch. So, I work here at Chelsea and Westminster Hospital, and I guess my qualification to speak on this topic, such as it is that I've been here for 11 years, and Chelsea, between our site and its outreach site at Dean Street in Soho, has the largest HIV cohort in Europe, and so I've had to get familiar with managing endocrine problems in these patients. And I guess if I thought about HIV endocrinology at all before I had this job, I thought about things like opportunistic infections affecting the adrenal glands, or perhaps mass lesions affecting the pituitary. And whilst in the last 11 years I have seen both cerebral lymphoma and toxoplasmosis causing hypopituitarism, that really isn't the bulk of what we see, and that's because our colleagues in HIV are now so good at treating this condition. So we're also not seeing the cachexia and wasting that was seen in early days in AIDS, and where testosterone and growth hormone was widely used as an anabolic agent in these people who had a short life expectancy. But we are perhaps seeing some of the effects of the prescribing habits that developed in those early years. So what we're seeing in the post-heart era of HIV treatment, where people are living long and pretty healthy lives with undetectable viral loads, is an excess of diabetes, insulin resistance, dyslipidemia, fatty liver disease, and premature cardiovascular disease, all of which one could talk about for an hour in itself, and I'm not going to focus on that in that talk. I'm going to talk about specific endocrine problems that I get referred through to me and see jointly with my HIV colleagues, both as a consequence of the long-term HIV, the therapies used to treat it, and other lifestyle choices or risk factors in this group. So the areas that I'm going to talk about today are hypogonadism, both male and female, problems with the glucocorticoid axis, osteoporosis, and briefly autoimmune endocrinopathy. So I thought I'd start with a real-life case that was referred to me a few months ago. The HIV clinic have set up an over-50s clinic, recognizing that their cohort are getting some advanced age-related problems and trying to head off these problems developing. And they referred me, it was a 5-word referral, so fairly terse, said low testosterone, LH, and FSH. So when I met this gentleman, he was a 51-year-old male with normal libido and erectile dysfunction. His testosterone was actually in the lower end of our normal range at 13.3 nanomoles per litre, was an early morning sample with an SHBG toward the higher end and completely undetectable gonadotrophins. But when you chat to him, he's actually been on testosterone for 2 years from his GP when he presented to them with fatigue and depression, and he hasn't really noticed any benefits in starting the treatment. So his treatments are as listed there. He's on Testogel 1 sachet a day. Trufada and Raltegravir are his HIV medications. He's on citalopram for depression. He's a little bit overweight, but normal muscle development, normal body hair. He's got testes, which are on the small side, and he thinks they have shrunk a little and are soft. He's got a normal prolactin and thyroid function. And if you look back through his monitoring in the HIV unit, looking at his CD4 count, he's had a high hematocrit and a high normal or high hemoglobin over the last 18 months. His PSA is normal, and there's no record of a testosterone measurement prior to the one just before clinic on our system. Coincidentally, at the over 50s clinic, they also picked up a low vitamin D, and this was at the end of August, so should have been much better than this, and they put him on some supplementation, and he was feeling quite a lot better. So I suspect most of the audience, like I was in clinic, are thinking, I'm not convinced this man is hypogonadal, and if he is, he appears to be overtreated with testosterone. He's got undetectable gonadotrophins, he's got high hematocrit. So I contacted his GP and got them to fax me through the investigations that had led to this treatment in the first place. And here they are. This is everything that had been done. So in May 2016, he had a testosterone of 6.7. And in October, after starting testosterone, it had gone to 14, and the exclamation mark had disappeared, so his GP was happy. And the patient didn't really feel any different, but he just carried on testo gel. So I'd asked the patient, had he been asked to come up specifically for an early morning sample? No, he hadn't. He couldn't remember if he'd been ill at the time of the sample, and he was on otherwise the same medications as he was at present. So I don't need to teach this audience that that's probably not enough to make a diagnosis of hypogonadism and commit someone to long-term testosterone therapy. So if this was an afternoon sample, he could easily have had a testosterone of 12 or 13 in the early morning, as we've seen from this data presented elsewhere in this meeting. Also, he may have had an intercurrent illness. If it had been repeated, there can be a 30% difference in early morning testosterone. So he's really not convincingly hypogonadal. And as he'd not had much benefit, he was quite happy to have a trial of coming off testosterone therapy. Now, he's probably going to hate me because he's probably going to feel unwell for a while. He probably will be hypogonadal with those suppressed gonadotrophins for some time, but I'm hoping his gonadal axis will recover and then we can assess him more fully. But I come across a lot of patients on testosterone who've been on it for many years, and often the pre-treatment diagnostic tests are lost in the mist of time. They may have moved from another centre, and it's often very hard to persuade these patients to come off treatment for re-evaluation. So looking at the literature, this really emphasises the problem that we have. If you look at the HIV literature, the reports of the incidence of hypogonadism are anywhere between sort of 9 and 70% if you look at cross-sectional studies. But they haven't always used early morning testosterone. If they have, they're very rarely used more than one measure. And so I suspect that testosterone is over-prescribed in this cohort. There's also excess of other risk factors that we know are associated with or cause hypogonadism, such as diabetes, insulin-resistant, visceral adiposity, and also there tends to be an excess of anabolic steroid and opiate use, and all of these patients, by definition, pretty much are on polypharmacy. So a recent study was interesting that I had a look at in 2014, looked at incidence of hypogonadism in HIV versus non-HIV infected men in a cross-sectional study, and they defined hypogonadism as a early morning testosterone of less than 10.4 or a free testosterone of less than 173.5, which is round numbers in the American units. And they found an incidence that was pretty comparable to matched controls, 9.3% in the HIV population, 7.2% in the HIV-negative population. But actually, if you included the men who were already on testosterone therapy, you ended up with 24% of men in the HIV cohort. So there were 15% of that cohort were already being treated with testosterone. So we may be overdiagnosing it, or it may be being overdiagnosed, but also we may risk underdiagnosing hypogonadism because men with HIV tend to run a slightly higher SHBG than control populations. And that's for a number of reasons. Maybe the chronic HIV infection. It's also commoner if there's hepatitis C co-infection, which is common. And sometimes you suspect it may have been from anabolic steroid use, which you've not managed to reveal. So in this study where they looked at around 600 men with HIV or without, about a third of those diagnosed with hypogonadism who were HIV positive had a normal early morning total testosterone, but when you used the calculated free testosterone, the levels were low. And that comes with some caveats because the free testosterone calculators are not really calibrated to use if people have a very high SHBG, which we sometimes see in HIV. So some people may be running an SHBG around 90 or 100. And so in those settings, you may have facility to measure free testosterone. We don't have that locally, routinely. I do have a number of patients who I treat with testosterone who've got a normal total testosterone, but in those cases, they have tended to have primary hypogonadism, so I've got high gonadotrophins to reassure me that I'm doing the right thing. Female hypogonadism is also commoner, so premature ovarian insufficiency is commoner in women with HIV. It's a lot easier to diagnose because, of course, the gonadotrophins are high, there's amenorrhea, there are hot flushes, so there are clearer indicators that it's happened, and it's important to treat because this group have increased risk for osteoporosis. I thought I'd talk about another case and move on to the adrenal axis now. So this is a patient who was picked up in the HIV clinic a number of years ago, presenting to his routine review with fatigue, septic arthritis, really quite marked limb wasting and abdominal swelling. And there are no prizes for spotting, really, that this man is floridly Cushingoid in appearance. The HIV physicians thought so too, and they measured a morning cortisol, which was undetectable, as was his ACTH. So this is the iatrogenic Cushing syndrome, and this is a potential due to interaction with antiretrovirals. Ritonavir used to be the most implicated antiretroviral. In fact, this is such a potent CYP3A4 inhibitor. It's not tended to be used for its antiretroviral actions now. It's used as part to boost the other antiretroviral levels in combination therapy. And there's another similar drug called cobicistat, which is used for the same reasons, which is increasingly used. And we can see interactions with exogenous steroids causing Cushing's and then subsequent adrenal insufficiency in this group. Ritonavir also induces CYP1A2, and I've seen some recent reports suggesting that it might increase your requirements for levothyroxine replacement. So colleagues in the HIV unit audited patients on cobicistat or ritonavir combinations, and in this year they identified just short of 3,000 patients on this combination. And this is not a hugely common problem that we're identifying, although I suspect we're missing a few cases. But 5 of those patients were noted to be overtly Cushingoid, who were found to have a low cortisol. And the implicated steroids, as you can see here, were particularly fluticasone and triamcinolone. So those little joint injections that people have and forget about can cause a problem. So we did some education amongst our patients and colleagues, and the HIV pharmacists helped design this nice little information card that's given out to everybody, starting on this antiretroviral combination. And in the following year, when we audited it, we only found 1 incidence of this interaction. So one to look out for. The MHRA have issued a warning about this, that one shouldn't use steroids with ritonavir, but if you are using them, then your best bet is beclomethasone for an inhaled steroid. You only about double the level of beclomethasone, whereas the levels of serotype and so forth skyrocket. So I'm lucky enough to work in a centre where I have not one but multiple HIV pharmacists, but if you're not that lucky, or even if you are but you don't want to bother them all the time, I have this in my pocket, as do all my HIV colleagues. So this is an app that you can freely download from the University of Liverpool called HIV iChart, which will tell you about drug interactions with all the different HIV drug combinations out there. And this is really useful, quick reference, and very easy and user-friendly. So moving back to our patient, he was switched off his ritonavir-boosted therapy onto a different regimen, and he also had his fluticasone stopped as he was reviewed and thought to have COPD, really, rather than asthma, and put onto tiotropium. He's no longer Cushingoid, but his adrenals remain suppressed, and this is now a couple of years post this quite prolonged exposure to both drugs. Very quickly, in the couple of minutes remaining, osteoporosis is commoner in people with HIV, and there's an excess of a number of general risk factors, but also there are HIV-specific risk factors as indicated here. And people, when they start antiretrovirals, will tend to lose bone mineral density in the first 1 to 2 years after starting, and it then tends to plateau. Tenofovir is particularly problematic, as it can cause a phosphate-losing osteomalacia. And colleagues in the HIV department have looked at switching from tenofovir to TAF, which is a formulation of tenofovir which is activated in the immune cells, and therefore your plasma levels are only about 10% as if you're on TDF. And they can see that bone density improves, but these patients respond to bisphosphonates if they have osteoporosis also, and they should be used if indicated by risk scores. Finally, autoimmune endocrinopathy can happen, and this typically can happen after you've started antiretroviral treatment with the immune dysregulation that may occur there. I've seen a number of patients with Graves' disease who are men without any family history, and it appears to respond as other patients with Graves. So in summary, a lot of what we're dealing with now is to do with drug effects and long-term living with chronic infection rather than acute opportunistic infections. Thank you very much for your attention, and my colleagues in the HIV unit.
Alison, thank you. As we predicted, there was quite a lot to cover. Unless anybody's got an absolutely burning question, we might move on in the interest of time, but I think people might catch you at coffee time for questions. Thank you for an excellent talk.
I'd now like to introduce to you Stephen Gallagher, who's from the Queen Elizabeth Hospital here in Glasgow, and he's going to tell us about how do I manage Paget's disease.
Thank you. So I've got no conflicts of interest relevant to this presentation. So Paget's disease, originally known as osteitis deformans, was first described by Sir James Paget in the latter part of the 19th century. And this is a condition which is characterized by abnormal increased bone turnover, which focally affects the bone. It's probably the second most common metabolic bone disease after osteoporosis. Perhaps one of the most famous sufferers of Paget's disease is this chap here, and that's Ludwig van Beethoven, whose deafness was due to Paget's disease. If I can make this go. Okay. So Paget's disease tends to be a condition that will affect older people. It's rare to see Paget's under the age of 40. It will often be asymmetric and often affect a single bone only. And it's interesting to note that it doesn't spread through the bone. Once it's there, it seems to be there. And if you follow patients longitudinally, you do not seem to see new lesions appear in other bone. It's more common in males, and it's also more common in British or British descent. And I think another thing which is interesting about the disease, if you're working in metabolic bone disease, that now we see much less Paget's than we saw 20 or so years ago. So clearly there's some environmental factors in play that we don't really understand. In terms of the pathology, there's a loss of the normal regulation around bone turnover. And there are different phases to this. There'll be lytic or blastic or sclerotic phases, and it just depends upon where in the bone cycle this patient happens to be at any moment in time. Osteosarcoma does occur, but it's fortunately very rare, and it's not something that you would expect to see in regular practice. Around, or perhaps up to 20% of patients with Paget's disease have a clear or strong family history, and there are well-characterized genetic links in at least 50% of these patients. But environmental factors, as I mentioned, are important, And there is some evidence to suggest that viral infections may be relevant in the pathogenesis of this condition, although again, there's some uncertainty around this. I think now the presentation of Paget's disease tends to be incidental, tends to be either a finding on incidental radiology, or it tends to be a finding of an isolated raised alkaline phosphatase. But patients may present with bone pain or deformity, although often the bone pain might not necessarily be directly pagetic, but may relate to, for example, adjacent osteoarthritis or abnormal ligament or muscle pain. It's unusual to see any other biochemical complications of Paget's disease. Perhaps rarely you might see hypercalcemia in a patient in association with immobilization. And of course, there are other complications which are generally related to bone overgrowth, or perhaps related to increased vascular supply to bone, which is particularly relevant in the context of patients with Paget's undergoing orthopedic procedures. Imaging is generally pretty diagnostic, and you probably don't need to do an awful lot more beyond imaging. Plain X-rays are highly suggestive of the disease diagnosis, but the gold standard test is radionuclide bone scan, where not only is there increased tracer uptake, as seen here, but the key feature is expansion of the bone. And once you see bone expansion, then you've really made the diagnosis. In terms of drug treatments, we have a number of treatments available, but effectively today, our primary options are intravenous zoledronic acid, 5 milligrams once as a one-off, or risedronate, given orally 30 milligrams per day for 2 months. There are a number of other treatments that have been used, and most of these are of historic interest now. The only one which I'll briefly come back to is denosumab, because this is something which is a question that often comes up about. So if zoledronic acid and risedronate are our treatments, which should we choose? We have one head-to-head study, which was a study comparing a single infusion of 5 milligrams of Zol versus oral risedronate, and patients were followed every 6 months or until alkaline phosphatase increased towards the pre-treatment value. And this slide shows the results of that trial in terms of alkaline phosphatase. The solid line here is the result in terms of zoledronic acid, and this is the risedronate. And you can see that after 6 months of treatment already, there was a clear separation in terms of efficacy with alkaline phosphatase and being better suppressed with Zol. And there was obvious signs of escape with the risedronate. This study has been followed up further and goes out now to 6.5 years. And results are really quite similar, that the alkaline phosphatase remains suppressed and remains suppressed to within the normal range with zoledronic acid, but has escaped with risedronate. And there's various ways of defining this disease relapse, and you can see in these curves here that quite clearly risedronate is inferior. And so if you are going to treat, then it looks as though zoledronic acid is probably the treatment of choice. Denosumab I mentioned, and I'll just mention it briefly because we really have no data around denosumab. The question that comes up often when you're treating older people is they may have chronic kidney disease, and zoledronic acid is not licensed for use with an eGFR below 35 mils per minute. And so there might be a role for Paget's disease, for denosumab in Paget's disease. But our only information comes from case reports. This is one from New Zealand and shows that there is efficacy in terms of alkaline phosphatase suppression, but there's also very quick escape as well. And the suggestion that's coming to the fore now is if we are going to use denosumab, then it's probably the osteoporosis dosing that we'll use, and that's 60 milligrams once every 6 months by subcutaneous injection. In terms of management of complications, well, of course, it depends upon what complication you're looking to manage. One or two things I think I would highlight. First of all, the orthopedic issue. there is an issue about the vascularity of bone before orthopedic procedures. And I think general good practice now would be to use intravenous zoledronic acid a couple of months before orthopedic surgery if this is going to involve pagetic bone. I briefly mentioned osteosarcoma. Osteosarcoma is bad news in the context of Paget's disease, as really there's very little that we can offer for patients with this complication. So in terms of guidelines, as we stand today, the most recent guideline has been the Endocrine Society guideline, which was published in 2014. And as stated here, this suggests that most patients, and I emphasize most, with Paget's disease should be treated with a potent bisphosphonate with the aim of restoring alkaline phosphatase to within the normal range. And so that would mean treating a lot of patients who effectively have asymptomatic disease. And the question, of course, is that a correct way to go forward? So to try and address that, the PRISM trial was carried out. This is a trial which was coordinated out of Edinburgh. And the original piece of this work was published around 2010. And this was a trial where patients were randomized either to receive symptomatic treatment, which effectively meant to deal with bone pain that wasn't responding to analgesia, or intensive treatment, which means that the treatment was continued in order to suppress the alkaline phosphatase to within the normal range, irrespective of how much treatment would be needed to do that, and irrespective of symptoms. This was approximately 1,300 patients who were, at this point in the trial, followed for around 3 years. In terms of the results, well, it probably won't come as a surprise that intensive bisphosphonate therapy very effectively suppresses alkaline phosphatase to within normal range, and certainly much more so than just symptomatic treatment. But I think the key things in terms of the results are what does this actually mean in practice? Well, first of all, in terms of quality of life, there was no difference at all. In terms of the requirement for orthopedic surgery or surgical intervention, no difference at all. Hearing thresholds, no difference at all. Bone pain, no difference at all. Although criticisms of this study were that, first of all, at baseline or start, around 50% of patients had normal alkaline phosphatase, and therefore you might think quiescent Paget's disease. And around 70% had already been treated before with a bisphosphonate. And so there were a number of questions still that perhaps were unanswered by the study, but perhaps the biggest one of all was the time it was done, zoledronic acid wasn't available, and so the question was, would the most effective treatment actually be better? And so there was a further extension to the PRISM trial carried out, and a further roughly 500 patients were then randomized to intensive treatment or symptomatic treatment with zoledronic acid. So in terms of the follow-up, well, once again, the intensive treatment arms successfully suppressed alkaline phosphatase. But once again, in terms of the effects on quality of life, there were no sustained benefits in terms of bone pain. There were no changes in fracture risks or requirement for orthopedic procedures. And therefore, this does not appear to support the extant Endocrine Society guidelines. Well, there is a question, I suppose, that remains unanswered, and that is whether or not patients presenting de novo with symptomatic Paget's disease that has not been treated with elevated alkaline phosphatase, with increased bone turnover, whether they might still benefit from treatment. So still a little uncertainty that remains. But as I mentioned, the Endocrine Society guideline therefore seems out of date, and this is about to be superseded. There's a further guideline which is going to be launched in January of 2019. This has currently been submitted for publication in JBMR and is just going through the final, hopefully, review processes. And without going through all the recommendations, I think the key recommendations in treatment which update the Endocrine Society guidelines are what are described here. So first of all, bisphosphonates are recommended for the treatment of bone pain associated with Paget's disease. And zoledronic acid is recommended as the bisphosphonate that's most likely to give appropriate response. It's recommended that in patients with established Paget's disease, the treatment goal should be to control bone pain using bisphosphonates or any other drugs, any other analgesics, as opposed to giving bisphosphonates with the aim of managing the alkaline phosphatase. So that's certainly a change from before. So in conclusion, Paget's disease is common. Diagnosis should be usually straightforward and based upon alkaline phosphatase and imaging, and you shouldn't really need to do much more beyond that. Pain and deformity are the most common symptoms, but one of the challenges always is whether or not the pain that a patient might describe is truly due to Paget's or due to the peripagetic pain related to orthopedic issues. And sometimes the only way you can tackle that is by trial of treatment. Treatment should be considered certainly where alkaline phosphatase is elevated in association with symptoms. But that goal of treatment is very much about managing symptoms, not about changing the long-term natural history of the disease. And where indicated, the treatment of choice would be a single infusion of intravenous zoledronic acid, 5 milligrams. That can be repeated if required, but as you saw from the data, that you should look at 5, 6, 7, 8 years of bone suppression without needing more treatment. But evidence to support long-term suppression of alkaline phosphatase as a goal is something that is not there. Thank you very much.
Thank you for giving us a very, I think, clear answer to that question. And we do have time for, I think, one question if someone in the audience has anything they want to ask. No?
If nobody has a question, I might just ask, given that we know something about genetic and environmental factors that might predispose to Paget's, can we say anything about whether we might be able to prevent it or prevent development of complications?
I don't think we know enough about, certainly, I mean, the question there is really primarily, I think, about the environment factors now, because something has happened in the last 20 years now. There are arguments that rage about, is it vaccination programs affecting viral parts to the disease, but I don't think we know enough at the moment to address that.
Thank you very much.
Thank you.
So now I'd like to introduce our fourth speaker, and that's Marie Friel, who's also from the Queen Elizabeth here in Glasgow. And Marie is going to tell us about that common conundrum that we have in the endocrine clinic of what drugs to stop when we're trying to investigate possible primary aldosteronism.
Thanks very much, Kerry, and thanks to the Society for asking me to give this short talk, although no thanks to them for asking me to follow Petros Peros. Never mind. So yes, I've got 10 to 15 minutes just to sort of take you through the diagnostic algorithms in primary aldosteronism with a particular focus on what medications to stop, because as Kerry has alluded to, that really is the commonest question that I am asked and that probably we're all asked as endocrinologists. So I thought I would start, as most of these presentations have, with a clinical case and an unusually prolonged referral letter to our hypertension clinic, which is usually, here's the blood pressure, please see. But this was a thoughtful GP who asked us to see a young man diagnosed at the age of 28 and started on an ACE inhibitor, which would be reasonable, poorly controlled on that agent with the addition of a calcium channel blocker subsequently. His blood pressure remains suboptimal on 2 agents. He has no past medical history, but he's a smoker with a BMI of 32. He's got normal renal function. Whilst I'm sure this is a case of primary hypertension, I would appreciate your review given his young age and relatively resistant hypertension. So actually a very reasonable referral given this chap's age. And we see him at the clinic and the history is as outlined, but we do some investigations to try and work out whether indeed he has a secondary cause of his hypertension. And at the blood pressure clinic, which is in the morning, we actually performed an aldosterone and renin measurement, and they are outlined there. And I'll come back to that again in a few minutes. So importantly, this test was done while the patient was seated within the clinic. So before I examine that further and take you through how we diagnosed this gentleman eventually with primary aldosteronism, I want to sort of just spend a minute or so debunking some of the myths that I think we're still coming up against, although increasingly less so in the world of primary aldosteronism. So I'm still told by some people this is not worth looking for, it's a very rare cause of hypertension. And not so. I think many studies now over the years have given a prevalence of primary aldosteronism of about 10% in a previously labelled primary hypertension cohort, and probably up to 20% of people with resistant hypertension. The next myth is that in order to be given a diagnosis of primary aldosteronism or to undergo investigation, the serum potassium must be low. And again, not so, and in actual fact, the majority of people who subsequently go on to receive this diagnosis have a normal serum potassium. The most common question, which is one that I'll address in more detail, it's not worth making this diagnosis, I need to stop all his antihypertensives, and that's dangerous and difficult to do. And by and large, that is not the case. And finally, this was one I came up against for many years, where I was told, look, it really doesn't matter, just lower the blood pressure and it makes no difference. And again, now there are increasingly consistent evidence showing that patients with hypertension due to primary aldosteronism have a significant excess of cardiovascular and metabolic morbidity compared to those with matched essential hypertension. So it's a diagnosis worth making. Throughout this talk, I will refer in a little bit of detail to the Endocrine Society Clinical Practice Guideline on the diagnosis of primary aldosteronism, which was updated fairly recently in 2016. And they give a very nice diagnostic algorithm, which take you through step by step how to make that diagnosis. And again, I'll refer to this in a little more detail as we progress. But really, the first stage, as is the case with many endocrine disorders, is to perform a screening test and to do that in patients with a high clinical suspicion. So who should that be in? So I would argue anyone with a severe hypertension at onset, or anyone with resistant hypertension, or anyone who presents probably under the age of 30 should undergo screening for primary hyperaldosteronism. Now, as mentioned, the absence of hypokalemia would not put me off screening, but the presence of hypokalemia would absolutely push me towards screening also. And that can be spontaneous or diuretic-induced. How do we do this screening test? Well, I think it's actually quite an easy test now to do. We would just say that ideally a morning measurement, although that can be negotiated, but a morning measurement in a seated, previously ambulatory patient is all that's required. And given that our blood pressure clinic often runs at least an hour behind, then they have been seated for quite a period of time before they undergo their biochemical assessment. And we simply measure in our lab plasma aldosterone and plasma renin concentration. I know many of you will still have plasma renin activity, or PRA. The requirement for supine and ambulant renin and aldosterone, I think, has now gone. And I think a single measurement and looking at these either separately or in a ratio is a very useful confirmatory test. But what about the medications? So this man is on ramipril and he's on amlodipine. Do we need to stop these in order to perform the initial screening test? And I would argue no. Now, we all know that virtually all, or certainly the vast majority of antihypertensive agents affect aspects of the renin-angiotensin system, affect plasma renin measurements, aldosterone measurements, and as a consequence, the aldosterone to renin ratio. And the effects of the main classes of these drugs on both renin and aldosterone and the ratio are outlined here. But I think if we all have a working knowledge of these effects, then for the majority of patients, we can at least interpret the initial aldosterone to renin ratio whilst being cognizant of the effect of their antihypertensive medications. So for example, this gentleman was on an ACE inhibitor, and an ACE inhibitor should usually stimulate renin and generally reduce aldosterone. And therefore, the presence of a low renin with a relatively high aldosterone in someone on an ACE inhibitor, I think, increases the level of suspicion. Similarly, beta blockade is something that I'm often asked about. Do we need to stop a beta blocker? And we know that beta blockers generally suppress renin. And whilst a low renin in that context may be difficult to interpret, not so if the aldosterone is also high, I should say. That would be more suggestive of primary aldosteronism. So I think we need to be pragmatic, given that we generally, certainly by the time patients come to our clinics, they're usually on 2 or 3 or more agents. And I think it's very difficult and often foolhardy to attempt to stop all of these medications. So for the majority of cases, we continue them, at least for the screening test, but we are very mindful of the effects of these drugs on both the prevailing renin and aldosterone concentration. Just a little additional note, it's always worth making sure the plasma potassium is normal at the time of screening, because if plasma potassium is low, then that can cause a sort of falsely low level of plasma aldosterone. There is an exception to this, and this is generally mineralocorticoid receptor antagonists. So patients on spironolactone, or less frequently eplerenone, I generally would stop these if I was screening for primary aldosteronism. Although, if it's easily done in your clinic and in your laboratory supportive, just doing an aldosterone and renin on these patients whilst they're on the medication is fair enough, because if the renin is still suppressed, then there is insufficient mineralocorticoid receptor blockade, and therefore you can still interpret the ratio on these medications. But I don't find that happens commonly, and usually we would stop these medications for 4 weeks to allow accurate evaluation of the renin and aldosterone system. So when is it necessary to alter antihypertensive therapy? And I have to apologise for the first point. I was going through these slides before I came up and spotted the typo that I've been blind to for the last 2 weeks. But when the initial screening is equivocal, and the sharp-eyed amongst you will see a high ratio, but a fairly low aldosterone, that's equivocal, and that might be affected by drugs. If the patient is going to move on to confirmatory testing, then again, ideally, I would try and stop the medications, or at least alter them if that was safe or feasible. And listed below are the medications that we know have negligible effects on the renin-angiotensin system. In practice, I usually stick with doxazosine and verapamil, but amlodipine, actually, a dihydropyridine calcium channel blocker, has very few effects. And if a patient is on it, as our patient is, I would usually continue this. So again, common to many endocrine disorders, we perform an initial screening test and then we move on to a confirmatory test. Who do we do this on? Well, we do it in patients where the screening test has given us suspicion of biochemical hyperaldosteronism. And some of you may use a ratio to do that, of aldosterone to renin. And obviously you need to know what your units are to know what your local cutoff is for a high ratio. But many people simply look at the renin and simply look at the aldosterone and tend to look at them sort of separately rather than as a ratio. But essentially, if your renin is below the level of detection and your aldosterone is inappropriate for that, and that usually means at least 218 picomoles per litre or more, then I think these are patients who do deserve further confirmatory testing. The Endocrine Society Practice Guidelines suggest that confirmatory testing if the ARR is elevated and the aldosterone is inappropriate, but they do not give an actual cut-off above which aldosterone is deemed inappropriate. Some have argued that it should be around the 400 mark. Some have argued 170, which is the post-fludrocortisone suppression test. But I think a pragmatic level and an evidence-based level is about 280. There are a few patients who don't need confirmatory testing where the biochemical diagnosis is so obvious, as is listed here: undetectable renin, significantly elevated aldosterone, and hypokalemia. And there are a few different confirmatory tests that patients can undergo. We tend to favour the saline suppression test. If you've all been in Glasgow for 3 days, you'll all be orally salt-loaded, so you could probably undergo some confirmatory testing right now. And I know that colleagues overseas, particularly in Australia, favour the fludrocortisone suppression test. There is really arguments for and against all of these, and it really depends upon what is locally available. So if we go back to our diagnostic algorithm, this is this chap's initial screening. So an inappropriate aldosterone with a relatively low plasma renin in the context of ramipril, which we continued at the time. We then brought him back for saline suppression testing. How do we do it? Well, that's our protocol here. And I think the most important thing is to look at the interpretation. And it's very straightforward. If the plasma aldosterone concentration suppresses to less than 140 picomoles 4 hours after a saline infusion. And it's very straightforward to confirm the diagnosis if it remains above 280. You'll have spotted that there is a grey area between 140 and 280 where we're not entirely sure. The most recent data from the prospective aldosterone prevalence study in Italy suggests a compromised cutoff of maybe around 190 picomoles. So if they fail to suppress below that, then I think that we would take that as fairly confirmatory of primary aldosteronism. And as mentioned, I would, if at all possible, stop the interfering antihypertensive medications for ease of interpretation, but also there's good evidence that stopping them improves reproducibility of the test, increasing it from 66% to 84%. So with this chap, we did switch him for 2 weeks only from ramipril to doxazosin, which he continued with his amlodipine, and he underwent a saline suppression test where he failed to suppress sufficiently with a 4-hour aldosterone of 305. So we had made the biochemical diagnosis of primary aldosteronism, and given that we're all mindful of the prevalence of adrenal incidentalomas, only then did we move on to image his adrenals, and he had a nice small left adrenal adenoma there, as outlined by the red arrow. And if we move back to our diagnostic algorithm, I've deliberately chosen a case of a young person with primary aldosteronism, because in this situation with obvious biochemical aldosteronism with an adrenal adenoma, then we can refer straight to surgery, avoiding adrenal vein sampling, which is a thorny issue and quite a long discussion in itself. So we referred this gentleman for a left-sided adrenalectomy, which he underwent. And 3 months post-operatively, his blood pressure was normal in a single agent, and he had a biochemical cure of his hyperaldosteronism. So his hypertension wasn't completely cured, and that might be because he also has superadded primary hypertension given his BMI and smoking status. But we certainly made a big difference to this gentleman, and he has avoided potentially 50 or 60 years of mineralocorticoid receptor antagonist. But his surgical outcome, I think, highlights an important point in primary aldosteronism, that surgery is often not curative. And it's very, very important that we make this point to our patients when they come to clinic, thinking that they continue to smoke 40 a day and eat fish suppers on a nightly basis, but have their hypertension cured if they undergo adrenalectomy. And these are very up-to-date and very nice data from 12 centres across 9 countries, led in Italy, looking at surgical outcomes after adrenalectomy. And the cross-hatchings indicate success or cure. So you can see on the right that virtually all patients underwent biochemical cure after adrenalectomy, but that on the left, their clinical outcome, so their clinical cure, i.e. not requiring antihypertensive agents with normal blood pressure, ranged from 20 to 60%. So I always say to patients that an operation will generally cure their hypokalemia, will probably cure their hyperaldosteronism, but there's a 20 to 60% chance of curing hypertension. And that is more likely if you're female, if you're young, or if you've been on smaller amounts of blood pressure medication. So there's an argument of people in their 50s and 60s on 4 agents with hypertension for 10 or more years about being more pragmatic and treating with medical therapy rather than surgical therapy. But again, that's a debate for another time. So very finally then, I just want to conclude by saying that primary aldosteronism, I'm hopefully preaching to the converted here, is commoner than previously thought. It is a diagnosis worth making, and it is less difficult than you might think. In most cases, antihypertensives can be continued at least for screening, as long as there's an awareness of the effect of these drugs on the renin-angiotensin system. Spironolactone and eplerenone usually, not absolutely always, need to be discontinued, and if at all possible, discontinue and swap for less interfering medications in the context of confirmatory testing. Thank you.
Thank you, Marie, and I think in the interest of time, we will give you a reprieve and we will move on to the next speaker. And that is Barbara McGowan, who's from London, and Barbara is going to tell us about how we decide which non-diabetic patients might benefit from using a GLP-1 analogue.
Good afternoon, and thank you for inviting me today to talk to you about which non-diabetic patients could benefit from a GLP-1 analogue. So can I just have a show of hands to ask who uses GLP-1 analogues in patients with diabetes? Quick show of hands. Fantastic. And can I also ask who uses GLP-1 analogues in patients without diabetes? Okay, so we have a few. Okay, so as the title says, I will not be talking about GLP-1s in diabetes. The use of GLP-1 analogues in patients without diabetes is currently limited, but I hope in the course of the next 10 minutes or so to show perhaps where we might be using these agents in the near future. So these are my conflicts of interest. So I'd just like to remind you, of course, that GLP-1 has effects which go over and beyond the effects on the pancreas, which are so well known to us, glucose-dependent insulin secretion and glucagon suppression. So GLP-1 receptors are expressed in many tissues, including the brain, the liver, the heart, the kidneys. So researchers have been trying to exploit the fact that GLP-1s have so many effects, multifactorial effects, to try and come up perhaps with uses, medical uses beyond the incretin effect. So what I'd like to start off with, just to remind you, with the GLP-1 agonists that we have in place at the moment. And we can divide these in two groups: the extendin-based therapies based on like I say, extendin-4, which, as you remember, was first discovered in the salivary gland of the Gila lizard. And we have exenatide, our first GLP-1, which was twice a day, lixisenatide once a day, and exenatide once a week. And on the other side, we have the human GLP-1 therapies, which are much more similar to the GLP-1 molecule. And we all know liraglutide as a once-daily dose. And then we have a whole host of weekly, although albiglutide is not available anymore in the UK. And most of us probably use dulaglutide, and soon we'll be able to use semaglutide in January next year. So starting off really with the appetite, the effect of GLP-1s on appetite control, I just wanted to remind you that GLP-1s control both the hedonic appetite system, but also, of course, the homeostatic aspects of appetite through the hypothalamus. And what GLP-1 does, it stimulates the POMC and CART neurons in the arcuate nucleus of the hypothalamus to basically switch on satiety, and it switches off the MP1 and AGRP neurons, which control hunger. And this property, of course, has been harnessed really into the GLP-1 agonist, liraglutide, for the treatment of obesity, which is probably known to you as Saxenda. Now, this is the only GLP-1 agonist which is licensed for the treatment of obesity. But the unfortunate thing is that it's not available within the NHS, and I think the few of you that did have your hands are probably using it in the private setting. So it is currently being evaluated by NICE, and we may hear something next year with regards to its use within the NHS. So how might we be able to use it? So these are the results from the Scale Obesity and Prediabetes trial. This was a 3-year trial of patients with no diabetes, but either or prediabetes. And what we can see at 1 year, these are patients that had to go a sort of 5-calorie deficit diet, as well as 150 minutes of physical exercise per week. So those patients on placebo lost about 3.5% of weight loss at 1 year, and about 9.2% on the liraglutide arm. And if we can see that at 3 years, that weight loss was maintained, at least a difference between the two groups. These are for the completers, whereas these results I've just shown you, the 1.9 and 6.1% is for everybody if we take the last observation carried forward. And when we stop the drug, what we see that, as for any chronic disease, weight tends to go back up, just as if you were to stop a blood pressure drug. Now, if we look at the patients who developed diabetes over time with liraglutide, well, this was less on the liraglutide arm, so 3% development of diabetes compared to 11%. So, of course, we know that if we're able to lose weight, we're also able to prevent the onset of type 2 diabetes. Now, what is the rationale for using Saxenda? Well, there's a very clear EMA stopping rule, and that is that if you have not achieved 5% of weight loss at 16 weeks, you should stop the medication. Okay, so if you are one of these patients that achieves at least 5% weight loss at 16 weeks, you are an early responder. So if you're an early responder, how well are you likely to do? So I thought I'd show you this. So this is the lines in the light blue are patients with diabetes, and the lines in the dark blue are patients with no diabetes or pre-diabetes. So essentially, if you are an early responder at 1 year, you're going to lose somewhere around 10% in body weight. If you do not respond at 16 weeks, then your weight loss is likely to be just under 4%. And I think this sort of helps us to inform patients of how well they're likely to perform, bearing in mind some patients are going to do much better and some patients are not going to do as well. So this is the licensing around Saxenda. So you're allowed to use it if your BMI is 30 or BMI 27 plus comorbidities. And there are some precautions associated with this, usually acute pancreatitis, acute gallbladder disease. Thyroid disease is up there, and this comes from rodent studies where C-cell hyperplasia has been seen with raised calcitonin levels, because of course rodents do express the GLP-1 receptor in the thyroid, but this has not really been mirrored in any of the human clinical trials. Now, looking ahead in terms of GLP-1 agonist and their therapy in obesity, there is a very interesting compound, which is semaglutide, which is a cousin of liraglutide in a sense. Again, it's very similar to the GLP-1 molecule with a couple of amino acid changes and a fatty acid spacer, which gives its longevity and its long half-life of a week. And I wanted to just share with you some of the phase 2 clinical trial data with semaglutide, again, given to patients without diabetes at different doses. And just to take you through, the orange line in the middle is liraglutide 3 milligrams. The top line is the placebo, and all the rest of the lines are increasing doses of semaglutide. And what we see in this phase 2 trial is actually 1 year, the mean weight loss was nearly 14%. And this is the first time that we have a single agent achieving mean weight loss of 14%. And not only that, the weight loss is still continuing at 1 year compared to other pharmacotherapies that we've had in the past, which tend to plateau at 6 months. So I think looking ahead, this might be a very interesting molecule, and the phase 3 clinical trials are currently underway, and we hope to hear hopefully next year, well, probably 2020. Now, GLP-1 agonists have also been shown to be very useful in sleep apnea. This is just one of the clinical trials with liraglutide, again, randomized to liraglutide or placebo, as well as a lifestyle intervention. And this is just to show you the apnea apnea-hypoapnea index, which reduced from 49 at the beginning down to 36.8 in the liraglutide group versus 44 in the placebo group. Again, showing that this could potentially be taken forward in sort of larger scale clinical trials in patients with sleep apnea. The other very useful use for GLP-1 agonists is in NAFLD and NASH, which of course is a very sort of topical sort of part of medicine. And what I wanted just to show you with you was some of the data at the moment. There are 20 ongoing trials, and I think these will be very interesting reporting over the next couple of years. But one meta-analysis in 2016, where they looked at 136 patients either with NAFLD and type 2 diabetes treated with either a GLP-1 receptor agonist or a DPP-4 inhibitor, showed that basically there was a reduction in biochemical markers of NAFLD, reduced signs of inflammation, steatosis, and fibrosis, which is very encouraging. And in one particular randomized controlled trial, which was very small, of course, just a small number of patients treated for 48 weeks. These were patients with NASH, where the primary outcome was resolution of NASH with a biopsy. Well, there was 39% resolution of NASH in the GLP-1 group versus the only 9% in the placebo. And I think this is, again, encouraging because I think we've been taught that actually fibrosis is irreversible. Indeed, cirrhosis is irreversible. But what we're seeing, both with GLP-1 therapy and with weight loss, that cirrhosis can actually be reversible as well as fibrosis. So I think, again, looking ahead, we might be using this therapy if the results are supported by the initial data. So one other area which is very interesting, of course, is the cardiovascular area or arena. And you're probably very familiar with, obviously, the use of GLP-1 and type 2 diabetes. And there have been many cardiovascular trials to really make sure that these agents are safe, following on from previous agents that would be used for type 2 diabetes, such as rosiglitazone, which have not been sort of, which have then been associated with increased cardiac risk. So there are many, many effects that GLP-1 agonists have on the heart, on blood vessels that are listed above. And what we have seen from the trials is actually that pretty much every GLP-1, or at least the long-acting GLP-1s, have shown a cardiovascular benefit. So these are just the results for liraglutide, semaglutide, and very recently for albiglutide. But dulaglutide has also shown a cardiovascular benefit when they looked at MACE, which is cardiovascular death, non-fatal MI, and non-fatal stroke. So this is an effect which is over and above its glycemic effect. And I think looking ahead, we may well be using these agents for the cardiovascular benefit rather than just the actual sort of glycemic effect. And indeed, I think the American guidelines, the ADA guidelines, and the ASD guidelines have already been rectified to suggest that we should be using these for patients who've had a cardiovascular event. Now, the SELECT clinical trial, I've just put that up there. This is a very large cardiovascular trial that's about to start next year on patients who are obese without diabetes, again, looking at the cardiovascular benefits of GLP-1 agonists. Finally, I just wanted to mention the effects that's been seen in neurodegenerative disease. This is very, very early data, but I thought quite interesting again. Now, we know that the development of neurodegenerative diseases such as Alzheimer's and Parkinson's has been linked to impaired insulin signaling. And I just wanted to highlight one little study where they've used exenatide once a week, which demonstrated to halt disease progression after 48 weeks treatment and a 12-week washout period based on a motor score. The diagrams on the right-hand side there just basically show the decline in dopamine agonist transporter, so the rate of decline was less on the exenatide group versus the placebo group. Now, this, of course, is early data, small numbers, and it's uncertain whether this finding really represents an underlying disease-modifying effect or just a long-term lasting symptomatic effect. And I think we will be seeing sort of trials going forward to try and answer this question. So in summary, GLP-1 agonist, that's Saxenda, is licensed for the use in obesity, but not yet available in the NHS. If it is approved by NICE, hopefully next year, I think the use is likely to be restricted to patients with much higher BMIs compared to its current licensing, because I think a third of the population would otherwise be eligible for it, and it would basically make the NHS pretty bankrupt. The new GLP-1 agonist semaglutide in phase 3 clinical trials looks promising agent for obesity. And looking ahead, GLP-1 agonists with proved cardiovascular benefits are likely to be used for reduction in cardiovascular events for patients with type 2 diabetes and increased cardiac risk. And there is some encouraging data for the use of GLP-1 in NASH and NAFLD, and very early data in Alzheimer's. So I'd like to thank you, and just to remind you that on the 14th of February, come and share St. Valentine's Day with us at the Royal College of Physicians, where the obesity update is taking place. So all of you who are interested in obesity, do come along. It's a really fun day. Thank you very much.
Thank you very much, Barbara. I was going to offer people a quick question or two. If anybody has anything to ask, we probably have about 1 minute if anybody's got any burning questions. And I appreciate this maybe getting off topic a little bit, but in common with the GLP-1 analogues within the SGLT2 class, we obviously have another class of drugs useful in diabetes, weight loss, no hypoglycemia, some with cardiovascular benefit. I know there's work out with diabetes looking at heart failure. Is there any work looking at them as weight-losing agents out with diabetes?
I think very, very early phase 1, but I think we're a long way from bringing in the SGLT2s for the treatment of obesity. But obviously, in the context of type 2 diabetes, they're very, very useful. And of course, they've also been shown to have a beneficial cardiovascular benefit.
I'm just wondering about the tolerability of these GLP-1 analogues. We're looking at doses that are quite a bit higher than we're using in diabetes, and we do obviously have limits with what we can use in practice and what you've seen there.
So the practicalities, at least patients on liraglutide 3 milligrams are participating in the clinical trials for those, as well as the semaglutide, is very similar to the side effect profiles that we see when we're using doses of liraglutide up to 1.8 milligram. So it's all about very slow titration, and informing patients about the possible side effects, nausea, which does get better. But it's not, the side effects are not really over and above what we've seen in our general use for type 2 diabetes.
Okay, thank you.
Thank you. And to round off our afternoon, we have my consultant colleague from Edinburgh, Professor Mark Strachan. I've been Mark's house officer and his registrar. Mark was my internal examiner at my MD Viva a few years ago, so Mark has made me sweat professionally on many occasions in the past. So it seems very apt to ask him to come and speak. I hope you'll ask him some challenging questions at the end to make him sweat a bit in return.
Thank you so much, Nicola. And yeah, I'd like to thank the organising committee for inviting me to speak on the topic of sweating. They also asked me to speak on diarrhea yesterday, so I'm not quite sure who I've offended on the organising committee, but I apologise unreservedly for what I've done. As Nicola has implied there, I've been a consultant now for nearly 20 years, and I wouldn't really consider myself an expert on sweating, I have to say. I've seen more than my fair share of people with sweating, and I have to say, it's always, for me, a heart sink referral getting in somebody with isolated sweating. It's a heart sink because I genuinely feel sorry for these people, because I can see how debilitated the symptoms are making them. It's a heart sink because I know the likelihood of me finding anything remediable is very small, and the likelihood that I can do anything for them that's meaningful is also very small. So it's not one of the happiest referrals that I see. Now, I thought that I would just start off with a little bit of anatomy revision for you all about sweat glands. So the most abundant sweat glands that we have are the eccrine glands. Oh, I was going to point to you, but I think the battery's gone. So they're the ones in purple. So these are all over our body, and these are the glands that produce sweat as we would know it, essentially a hypotonic solution. The highest density of sweat glands, or eccrine glands, is on the palms of our hands, the soles of our feet, and over our head. Now, I said at the outset, I didn't really consider myself an expert on sweating, but whilst we were waiting for this session to start, I have to say that Petros Peros demonstrated a very, very substantial knowledge about sweating, and he was able to inform me that the thermoregulatory effects of sweating are very, very important in evolutionary terms, because most animals lose heat by panting, but that's not very efficient, whereas sweating is a very, very efficient way of losing heat. So I would consider Petros Peros a real expert in sweating, and in fact, he did say to me that he's happy to accept referrals from anywhere in the United Kingdom. So the majority of the eccrine glands are innervated by the parasympathetic nervous system, cholinergic system. Those glands on the palms of our hands and the soles of feet are adrenergically or sympathetically innervated. And of course, that explains why when we get anxious, we get very sweaty hands and feet. The other main group of sweat glands, of course, are the apocrine glands. So they are predominantly located in the axillae, around the genitals, nipples, and in the perianal area. These glands are associated with hair follicles, so they actually secrete their sweat out onto the hair follicle. And the sweat that's produced by the apocrine glands is actually different from that produced by the eccrine glands. It's got a much higher fatty content, a cholesterol content, so it's a more oily sweat. And as we all know, when that is acted upon by bacteria, it releases an odor. And that is said in some individuals, although not many in my experience, to have a pheromonic benefit. The apocrine glands are innervated by the sympathetic nervous system. So again, they are releasing their sweat in response to emotion and anxiety. And I thought you'd be interested to know that mammary glands, ciliary glands, and the ceruminous glands are also forms of apocrine glands. Now, not many endocrinologists, I suspect, know what ceruminous glands are, but these are the glands that make earwax. The good news, though, for all of us is that these are not adrenergically innervated, so when we are getting emotionally excited, we don't start pouring wax all down the side of our head. And just for the sake of completeness, sebaceous glands, they're not obviously sweat glands. These, again, are located all over our body, not on the palms of our hands or the soles of our feet. And they produce sebum, which, of course, is a waterproofing effect. Now, so you get primary and secondary hyperhidrosis. Primary hyperhidrosis is that affects usually one or two localized areas. So classically, of course, the palms of the hands, soles of the feet, and the axillae. Now, this in my book is a dermatological disorder. This is not one for us at all. Classically, primary hidrosis does have a familial tendency. In fact, there are probably some autosomal dominant forms. Onset in teenage years, and there are a whole variety of different treatments in a sort of escalating algorithm. So most general practitioners will start off with topical agents, particularly things based around aluminium salts. I have the one person I think I really made a difference to with hyperhidrosis was a teenage boy who came in with drenching axillary hyperhidrosis, and I referred him for Botox treatment, and that was astonishingly effective for him. There's another treatment called iontophoresis that dermatologists use a lot, which is basically putting your, you can do this for your hands, for your feet, and indeed your axillae. You put your hands in a bath of tap water, pass an electric current through it, and by weird mechanisms that are not entirely understood, that can have an effect on sweating frequency. You usually need to give about 7 treatments over a month, and thereafter every week to month as a top-up. And then you get the destructive treatments that are reserved for the more severe forms, which are things like sympathectomy. There are sort of funny microwave techniques that can be used, or surgical techniques, to dissect out the sweat glands, particularly in the axillae. Now, of course, what we tend to be referred are people with secondary or generalized hyperhidrosis, occurring typically over an extensive area of the body, although often the head, neck, and shoulders, may or may not be associated with flushing, often occurring at night, described as drenching by people. Often people, this will be familiar to you, that they're having to get up and change their night clothes. Episodes occurring during the daytime, often with no real precipitant, just out of the blue, just individuals starting to pour with sweat. And of course, these forms of hyperhidrosis can be associated with systemic disorders. And of course, the reason that we get referred these people is that there is a long list of endocrine disorders that are associated with hyperhidrosis. There is, of course, though, a very long list of non-endocrine causes as well. And one of the things I do when I see referrals is scrutinize the medication list very, very carefully, in the hope that there might be something there that I can write back to the GP and say, actually, try stopping this medication. But as you know, classically, tricyclics, SSRI agents, are associated with sweating, and indeed withdrawal of agents like SSRIs and opioids is also associated with sweating. Lymphoma and chronic infection, of course, are recognized causes. What I would say about lymphoma, because lymphoma is something that you worry, you know, like, am I missing somebody that's got a lymphoma? The sweating that occurs in the context of lymphoma is, of course, a B symptom. It occurs in the context of often weight loss and fevers. This is usually, and in fact, virtually always, in the context of high-grade lymphomas. So you are very, very unlikely to get somebody coming along to you saying, yeah, I've been having major issues with sweating for the last 3 years with no other real symptoms, and that they will then turn out to have a high-grade lymphoma. So I think it's something that we worry about, but actually in practice, for the people that are presenting to our clinics, the likelihood of having a lymphoma is very, very low. And then you'll know there are some neurological disorders, Parkinson's, weird neuropathies that are associated with sweating as well. Now, in my experience, by the time somebody is referred to us, all the easy stuff has been excluded. So the GP's already done thyroid function tests. They've already done a full blood count. They've already done a CRP. They might even have done an ESR. And of course, they're all normal. Because if these things are abnormal, then they'll be referred into another relevant specialist. If there's a concern about estrogen deficiency in a woman, invariably, HRT has already been tried, or the woman does not wish to have that treatment. And of course, the usual topical treatments have always also been tried. So we're getting a really raw deal by the time these people come to us, because everything easy has been done or excluded. And so we're left with trying to identify real rarities often. And so the reality is, by the time, it's almost paradoxical, by the time somebody with sweating comes to an endocrine clinic, the likelihood of an endocrine disorder is actually vanishingly small. The one big take-home message that I would have for you, the one thing, again, that I think many of us worry about is when somebody comes in with sweating is, could they have a carcinoid somewhere? Could they have a neuroendocrine tumor? Could they have a carcinoid tumor somewhere? Now, I've sat through hundreds and hundreds of neuroendocrine tumor multidisciplinary team meetings. Believe you me when I say this, that people with carcinoid syndrome do not present in endocrine clinics. So somebody will not come into an endocrine clinic with isolated sweating, and they then will miraculously turn out to have a carcinoid tumor. People with small bowel carcinoid tumors either present with a surgical emergency, usually small bowel obstruction, or they'll have had a CT done for some weird reason, and they've got a liver full of metastatic disease. Very occasionally, you might see someone like this. This is a picture I've just downloaded from the internet, but I actually had a lady who looked very similar to this just only a month ago, who came through the emergency department in the Royal Infirmary in Edinburgh. Now, this lady did turn out to have very severe carcinoid syndrome. She had urine 5-HIA levels of over 700. And this lady did have sweating. That was one of her symptoms. But this lady also had torrential diarrhea. This lady had been having recurrent syncopal episodes for the last 12 months. And the cardiologist, for slightly dubious reasons, had put a pacemaker in her. She had been given an asthma inhaler even by her GP for wheeziness. This lady had full-blown symptoms of carcinoid syndrome. So you're not going to miss this diagnosis if she does come to an endocrine clinic. But somebody coming in with sort of a history of 3 years of night sweats in isolation with really not much else going on and looking physically very well, they are not going to have a neuroendocrine tumor in my book. Now, I'm sure somebody will say, well, actually, I have seen that, but it is very, very, very rare. So, how do I investigate sweating? Well, I do take a careful history. It's probably the most useful thing I do in that consultation. I am obviously on the lookout for alert symptoms of systemic illness. I'm interested in the duration, and obviously my concern about significant pathology will fall exponentially with the duration of the symptoms. As I said before, I'd take a careful drug history. This is my personal observation and experience, but I often find that in people with generalized hyperhidrosis, who there is no underlying endocrinological or pathological cause, that there often has been a history of weight gain prior to the onset of a history, and often significant weight gain. And I often wonder if it's just a sort of insulation thing, that the more adipose tissue you have, the less effective your thermoregulation is, or maybe the more effective your thermoregulation has to be, and that ultimately results in sweating. the extent of I've written here these list of things that I do. Do I examine everybody for lymph nodes and hepatosplenomegaly? I don't think I do, and I think that is tailored to the individual. As I said earlier, usually the ones in brackets, the initial simple blood tests people have had done. I do check an LDH level, and if somebody's got a normal LDH, a normal CRP, and a normal ESR, and a normal full blood count, then the likelihood of something like cancer has to be very, very small. And so I would not be in a rush to CT that individual unless there were other alert features in the history. Do I practice what I've just preached to you and not do a 24-hour urine collection for 5-HIAA in people presenting with sweating? Well, of course I don't practice what I'm preaching to you. I do very often request a 24-hour urine collection, and I will hold my hand up and I will say that that is often a therapeutic 24-hour urine collection, both for me and for the patient, to make them feel that at least I've taken things seriously and that I've excluded very, very rare but important causes of hyperhidrosis. I don't often measure urine and plasma metanephrines, again, unless there is a very clear history that's suggestive of pheochromocytoma. I'm not sure how helpful that's been for you. In terms of how I manage it, again, I try and push lifestyle measures as much as I can and say this observation about weight gain. I often have long discussions with people about the importance of losing weight. They will have done all the other usual things about not having a heavy duvet and thick night clothes and things like that. These will already have been tried, but I do reiterate that. If there are offending drugs, I will stop them if possible. In terms of pharmacological interventions, my personal experience is very unsatisfying with most of them. I think HRT is effective. We know that. It is effective for treating sweating and flushing in postmenopausal women. But obviously, we all know about the concerns around that. Anticholinergics are logical therapies because, as I intimated, most of our eccrine glands are innervated by the cholinergic nervous system. The problems with drugs like oxybutynin is the side effect profile. Particularly if you have older people, the side effect profile can be worse than the sweating. So I've not found. I always discuss it with people as an option for them to try. And maybe it's just the way I sell it, but there's not often a huge take-up. Beta blockers have some efficacy, particularly for palmar-plantar hyperhidrosis, particularly in an anxiety context. And there is a literature around clonidine, which is, many of you know, as an alpha-2 agonist. Again, it has a side effect profile. So, the people that are referred to are clinics with isolated sweating. Rarely, in my experience, have an endocrine disorder. If they have had an endocrine disorder, it's actually been picked up before they've been referred to us. Dermatologists are unquestionably the best people at managing primary hyperhidrosis and probably even secondary hyperhidrosis as well. And as I said, the management of secondary is often limited by drug toxicities. Thank you very much for your time.